Hey everybody, welcome back. This is going to be lecture number 10 of the 13-part series, and this is going to go over EMDR, which is eye movement desensitization and reprocessing. This is one of the well-accepted interventions for trauma treatment, possibly the most accepted. However, exposure therapy, which we discussed prior to this, has been around the longest. But this was discovered in the early 1980s and then developed and put into practice around the mid 1980s. And this was discovered by Francine Shapiro, who was with us only until about 5 or 6 years ago now. So we're going to go over this process, and this is also a lens that you view therapy through if you're a clinician. If this is the lens that you choose, which it is for me, this is the main lens that I usually look through when working with my clients as often as possible. However, it doesn't always fit in every scenario. So first we want to know what it is. So EMDR is about helping the brain process information like what we discussed before, where when you go into REM sleep with rapid eye movement, your brain is kind of downloading the information from the day. It's discarding any unuseful information, and it's filing any information and categorizing it and connecting it to other information that you already know in order to build your ability to understand the world. So these are memories that are stored without any charge to them, so no emotional energy, so you don't have that activated charge like you do with the trauma memory. And any of the negative or unuseful cognitions, beliefs about yourself are discarded because those do not align with our goal at our core, which is survival as a mammal. So what we need to know about is the adaptive information processing system, because this is kind of what EMDR runs off of. And so this is basically the system that categorizes files and is able to recall information as necessary, dependent on the stimulus that you're receiving in the present moment. So if I'm hungry, then my adaptive information processing system will pull up foods, and then maybe it'll pull up sweets or fruits or whatever I decide that I'm kind of looking for. So the stimuli are incoming information, things that you can see, hear, touch, taste, and smell from the external world. And then your brain analyzes these activating events or triggers, senses, and it is coded into your adaptive information processing system. And then you have, from that information and from that perception or coding or just deciphering of that information, your brain then determines an output that it's going to release from that adaptive information processing, and that results into an emotional reaction, which then guides a behavioral response. We've visited this before in previous lectures, but it was known as ABC, which is the REBT, or Rational Emotive Behavior Therapy approach. So there's an activating event, which means something happens in the external world. You have a belief or perception of what that means, and that creates a consequence, which is an emotional response and a behavioral choice. So trauma is stuck in our neural networks. So it's basically stuck in our active memory. It hasn't been processed and coded and put into appropriate files and categorizations so that we may recall the information appropriately, and therefore it gets triggered too easily because it is stuck in that neural process. Any memory of a traumatic event can connect to a stimulus in the present moment. So you can see a blue door and it can remind you of an attacker who had blue eyes or was wearing a blue shirt. You can see a brick building and it reminds you of a building that you were in or lived in as a child, that you experienced any kind of trauma, abuse, something like that. And this association is going to be connected to an emotional sensation, negative beliefs and feelings that were happening in that moment. Those things were not discarded because this has not been processed correctly. So the goal of your adaptive memory network and everything that's involved in that is to utilize these emotional experiences, but they need to be discharged, completed, because they're unnecessary after the event. And so what happens in EMDR is bilateral stimulation, which is kind of, not kind of, but it's when you see the individual following the fingers or the light bar of the clinician, or sometimes they'll use tapping on the shoulders, or they'll use little paddles that vibrate, alternately back and forth in your hands. And when you do this, there's new neural pathways that are created, and this helps the brain to process the trauma information that's stored in the other neural networks, the maladaptive ones, the ones that are not useful, the ones that are causing us to have those reactions in the moment with physical responses or over responding in our emotional reactions. Your perception of the current situations, what are happening, get linked to these associated memory networks automatically. This is something that your brain does automatic. So if your brain sees a fruit, then it's going to be able to associate very quickly with other fruits. What is useful is learned, stored in our memory networks with appropriate emotions, and made available to guide us into the future. So this means that useful information is stored in our long-term memory. The negative beliefs and emotions, overcharged emotions, are discarded because they're not useful at that moment. And therefore, this information is useful to guide our movements and our decisions into future experiences. So over responding, having an emotional reaction to something in the present moment is not useful. But being able to use information from past experiences to say, hey, this may not be the best idea, I should consider other options, that's useful. That's what we need. That's where we need to be. Trauma makes that difficult and disrupts that process. And so EMDR is meant to try and help the adaptive memory network fix these traumas that are stuck in our neural pathways that are not useful for us. So EMDR uses a three-pronged approach. It targets past experiences that we believe are the roots of the tree. They're the core, the foundation for the symptoms that the person is experiencing. So essentially, if these past experiences can be processed correctly and downloaded and filed into the adaptive memory network in an appropriate way, the symptoms should cease to exist because they only exist because of that stuck trauma network. Second prong is targeting present situations. So triggers that happen now that cause disturbances or cause symptoms for the individual. So not only is EMDR going back and trying to help your brain process these stuck trauma networks, these past traumas, but it's also helping to engage in figuring out how to process and deal with and improve our response to these stimulus in the present moment that are tied to the past traumas, but these things in the present moment that cause us to have these reactions. So being in large crowds or flying on an airplane or being in the dark, those are triggers that are happening now tied to the past trauma that we can also target with EMDR to help decrease, minimize, or even eliminate the emotional charge that you experience when you are exposed to flying on a plane or being in a large crowd or being in the dark. And then, of course, finally, third prong, future. So EMDR can help the individual identify and what's called install appropriate responses to future situations. So if you're afraid of being in crowds, EMDR is useful with many people at helping them prepare for in the future when they are in crowds, how they would like to respond, how they would like to react in those moments. EMDR is able to help you improve your ability to do that with the installation phase, which we'll talk about later. So EMDR's three-pronged approach is basically it can help process past traumas, deal with present triggers, and prepare for future situations. The basic components of EMDR are the image. So when you're in a session, the clinician will ask you to basically bring up an image that represents the worst part of that memory that you're targeting. You do not have to describe the image. You just merely have to pull it up in your own cognition. EMDR is excellent in the sense that you don't necessarily ever have to explain any of the events in any detail that occurred. You just have to bring them to your awareness, and that's the most exposure that you need to have. So you don't have to sit there and retell the story and relive the story. Just simply bring up an image, sometimes a movie, um, and hold that. And then the negative cognition. So now it's identifying what is it that this incident, this trauma, what does it say about you? And this is not something that's necessarily true or is true at all, but this is what the negative cognition that developed is because of the experience. So, for example, if someone identifies a time that they were assaulted as a teenager, um, the negative cognition might be I'm powerless, or I'm weak, I'm not safe, something like that. So we identify that negative cognition because we want to know what are what is the trauma making you believe about yourself, at least in that moment. And a lot of times it's, most of the time it's making you believe that now in not only situations that mimic that one, but situations, even just being in an area that looks similar to that area where that happened, or being, if it was, two adult men who assaulted you, then being in an around men or something like that. That negative cognition comes up in your brain, whether you're aware of it or not, and causes the individual to experience some kind of charge, which when I say charge, it means an emotional response and a negative belief and just feeling that trauma coming back up. The positive cognition is the clinician will ask you to identify what it is you would like to believe about yourself instead. And a lot of times this is just simply the opposite, right? Like I am safe. I'm not powerless, things like that. And this is because we want you and your brain, which is you, we want you and your brain to basically install this new positive belief to replace the negative one. So this is CBT in a sense, right? Cognitive behavioral therapy, which many people are familiar with. Changing your thinking will change your emotions and change your behavior, and the three are interconnected. But EMDR uses bilateral eye movements, right? Stimulation, back and forth, follow the finger, to help you, quote, install this positive cognition. So it can strengthen this neural network, like we mentioned before, of I am safe. So that becomes more powerful than I am not safe. That neural network can diminish slowly, slowly, slowly over time and through bilateral stimulation with EMDR, and the new positive cognition can be strengthened and literally the neural pathways will grow larger. And so now the electricity wants to flow along this positive neural network that says I am safe, and the one that says I am not safe, that negative neural pathway gets smaller, smaller, and eventually is obsolete. Next, we need you to target the emotion. And we're going to tie this to the last one, which is physical sensations. So when in a session for EMDR, when you're on the phase of bilateral stimulation, the clinician will ask you to identify any emotions that you felt in that moment or that you feel now. And then they'll ask you to identify any physical sensations in your body as you bring up that image. So essentially, EMDR runs on a scripted protocol. It's pretty much the same across the board for anybody you go to. Different therapists or clinicians are going to adjust accordingly to the client's needs or patient's needs, but there is a script that's followed because this is what has been proven to work through clinical trials. So the clinician will ask you to bring up that image that represents the worst part of that memory. And then they will ask you to kind of scan your body and notice, are there any sensations, any feelings, emotions, sensations in your body that you experience right now as you think about that? And so you might say, yeah, my stomach feels nauseous, or my chest feels tight, or my shoulders are hurting. And so the clinician will then say, okay, I want you to hold that image of, and they might repeat it if you told them, or they'll just say that image of the worst moment, and I want you to notice that sensation and follow my fingers. And then that's when you get to the bilateral stimulation phase of EMDR. There's two kind of main approaches with this. There's the single memory processing. So this is a memory that's all connected through the brain waves, and it was one event. And such as, I was assaulted, or I was in a car wreck, something like that. And that doesn't mean that that's your only trauma, your major trauma. It doesn't even mean that that's the main one. That might not be what we call the target node or the touchstone memory, which we're going to get to in just a second. But it's one that is significant, and that's one that you want to process because it causes you, with the clinician, you found that this is a significant event. This is definitely playing into this. Whether it's the main one or not, it's definitely causing symptoms, and it's definitely a stuck trauma network. So you can see that with the single memory processing, the whole event is just one memory along the neural pathway. And that's what we want to target. We want to clear this right there, okay? Now, with multi-memory association channels, this is usually the individual will have a belief about themselves. Like I'm, yeah, I'm no good, I'm weak, I'm not worth anything, nobody will love me. So this is, the individual may have multiple, here's a trauma, here's a trauma, here's a trauma. And these traumas all combined, they associate because they're similar in some way. And so they then create this belief that is negative about the person as a whole because of these things. So over here, when you're looking at single memory processing, as you do EMDR, you'll see changes in the sensory images and sounds from that moment, that memory. The memory will not go away. But what it will do is some people will explain it when they go through EMDR, they explain it as it'll dull. The colors will fade, the sounds will fade, the smells will go away. The memory will still be there, but you won't have the negative belief about yourself like I am weak, I am worthless, I am not safe. That will not be there if the memory is cleared. And you won't have the emotional response and the physical sensations when the memory is pulled up. So those dissipate, but the memory itself does not disappear. EMDR does not get rid of memories. It does not change anything about your experience or memories. Those are all there. It just helps your brain process them, store the information, but get rid of the charge, rid of the negative emotions, rid of the negative beliefs about yourself. In multi-memory channels where you're targeting multiple and it creates this belief, the belief will change. So you will start to believe like, okay, it wasn't my fault. It's not my fault that I was taken advantage of. The stimulus, the stimuli, the things that see, hear, touch, taste, smell, those will fade. So the sensations, the emotions, those will also fade in association to that multi-trauma or complex PTSD if you meet that criteria. So in EMDR, the end goal is to reach the target, the node or the touchstone memory. Now what's going on is the target node here is the major event. So let's just say it's this. It's this single memory processing. Let's stick with this one to keep it simple. So you had this major event, and this was when you were 15, you got jumped by like 5 people and they stole your stuff and beat you up so bad you were in the hospital. That is this, right? And now you have a fear of groups. Well, we're not going to be able to just get to this and process it and move on, right? So what happens is you have these channels here. And these are what we have to clear sometimes. And once those are cleared, then you can go after the target, the main event. Now what those channels are could be imagery from the event, stimuli from the event, sounds and thoughts, physical sensations, negative belief, emotions, or affect of that moment. So all of these up here have to be cleared so that the target memory can be cleared. And that's done through bilateral stimulation or eye movement. Okay, so now we have the 8 phases of EMDR. So phase 1 is going to be history and treatment planning. So history means identifying what's the presenting problem, taking a risk assessment. So seeing, does the individual disassociate? Are they able to state shift, which means move from anxious to calm with assistance, because we don't want somebody getting stuck in a flashback and being unable to come back from it. If they are unstable or have high risk with this, then you need to focus on stabilization, crisis intervention, making sure that they're safe before you can move forward. And what you can do is, if they are relatively stable but they still have limited ability to manage their anxiety, you want to first strengthen, add resources, teach affect management skills, continue to build rapport. You need to teach grounding techniques. If possible, or if applicable, you might need to do some work with disassociation. And then you can wrap back around and you can go into phase 2. So once the patient or client is able to manage their emotions well enough and tolerate uncomfortable sensations and self-regulate, and they also have identified that they do have some supports and resources that are good enough for right now, we move into preparation. This is just simply where the clinician will explain EMDR theory. They'll teach you kind of about what I'm teaching you now. They'll introduce you to the basic resources, and they'll help you do something called creating a safe, calm place, which means helping you identify something that you can get to if you feel unsafe or overstimulated in session. You can add a trigger word to this, and trigger doesn't mean negative, it just means something that stimulates. So you can add a word to this and use the install method so that this word has an association with this calm place, and this word can be used during session. And the clinician will show you where they'll sit, how it works. They'll make sure you understand that at any point you can raise your hand to stop it, because the clinician will not stop the stimulation, bilateral eye stimulation, just because you become upset or if you start to kind of cry or feel uncomfortable, because that means the brain's working something out. So you have a stop method though. If you raise your hand, the clinician will immediately stop, no questions asked. Now there's caveats to this. If the clinician sees that you're just not tracking, or there's something else going on that they're worried about, they're going to stop, even if you don't tell them to. But they're going to try and push through as long as you don't give them the stop signal. So once this is all explained and the client and the therapist are both ready, phase 3 begins. This is the assessment. This is where you choose target memories using the three-pronged approach, past, present, future. This is where you're going to identify the image that we talked about, the negative cognition, the positive cognition. You're going to identify how disturbing it is for you so that we can track any progress through the EMDR session and phases. And once these are all collected and taken down, then the clinician will move into phase 4, which is the actual phase where the eye movement is used, the bilateral stimulation, BLS. So phase 4 is desensitization. So you're going to be linking the image that you brought up to the incident and the negative cognition that it makes you kind of believe about yourself, as well as the emotion and body sensations that you have. The clinician is simply going to have you go with that or focus on that, and then do back and forth with their fingers or use the light bar or whatever you agreed upon to begin the brain to process. Once the clinician does 20, 25, sometimes 30 back and forth with their fingers, let's just say we're doing the fingers just to keep it simple, then what they'll do is they'll stop, bring the fingers down, and they'll tell you something along the lines of take a breath, let it out, what do you get, or what do you notice? And then this is where you will share anything that changed, anything that's changed in the body sensation, anything that changed in the memory. If you had another memory come up, anything. You could say, I just started thinking about that I'm hungry. There's no expectations. There's no, guiding you to try and get a certain answer. And sometimes there's no change. So what will happen is, if there is a change, then the clinician will continue to process with BLS. They'll say, so you say like, yeah, I noticed that I started to feel something in my shoulders, and then like some of the colors in the image, it's the same image, but like the colors kind of faded a little bit. And then the clinician will simply respond, okay, go with that, follow my fingers, and they'll do it again. As long as you keep having a change, they'll continue to do this. right? And then if there is no change, the clinician might change the direction of their fingers. They might change the speed. They might try tapping or sound or light bar or something instead. And um, they might also use something called cognitive interweaves, which means they might interject just a couple sentences here and there to try and get you to kind of keep moving forward. But if there are no changes after 2 or 3 sets of doing the eye movements, the clinician will then move on and they will go to, well, first they'll take a measurement. So they'll take something called the SUD, which means they're going to ask you about your subjective units of disturbance, which means, on a scale from 0 to 10, where 10's the most disturbing you could imagine, and 0 is not disturbing at all, when you bring up that image of that memory, how disturbing is it to you now? And this would have been taken before in phase 3. So now we want to see that the SUD is down to a 0 or possibly a 1 if there's something in the way that just doesn't allow it to be a 0. Like, well, I can't know for sure that I won't, that I'll be okay if I get attacked. I mean, if 10 people attack me, I can't say I'll be safe. So I can't say it doesn't disturb me at all. But we want to try and get it down to 0 pretty much always. Once that's done, we move into phase 5, which is installation. So installation is trying to, now that the target or the memory has been processed and cleared, we now want to try and install a positive cognition to replace that negative cognition. So the clinician will ask you, they'll repeat your positive cognition, which was, let's just say, okay, so now how does the statement, I am safe, how true does that feel to you? Does that still fit, or do you think there's a better statement? And so a lot of times the client will say, yeah, I think that's right. And other times they'll say, no, I think it's, I am in control. Like I have control. They might change it. And then the clinician will just say, okay, well, bring up that positive belief of I am in control. And they'll record something called VOC, which is validity. And they'll ask you from 0 to 7, how true does that seem to you now, where 7 is completely true and 0 is completely false? And so let's say you say a 4. Then they'll say, okay, go with that, and they'll have you follow their fingers. And then they'll check the VOC again, the validity of cognition again, and if it goes up, which is good, right? 7 means you completely believe that I am in control or I am safe. If it goes up, then they'll continue the bilateral stimulation again until it reaches 7. Or 6 if there's something in the way, like, well, I can't say I'll be safe for sure. You're always a possibility where you're not in control or not safe. So 6 is okay in that sense. We call that 6 if it's ecologically, acceptable. So if you get to a 6 or a 7, then the clinician will do one more set of bilateral eye stimulation to strengthen that belief, and then move on to phase 6, which is the body scan. The body scan, basically the clinician just has you notice, so they'll say, do you notice any disturbances or any sensations in your body, right? So you'll link sorry, I forgot to tell you, you'll link the image of the negative event that you had from the beginning, and then you'll bring up the positive belief of I'm in control or I am safe, and they'll say, do you notice any sensations in your body? If you do, then the clinician will say notice that, and they'll do some more bilateral stimulation because they want to try and clear that, because that means that there's still something left that hasn't been cleared out. You're still having a charge to that memory, and you shouldn't once it's cleared, because it's been downloaded into the adaptive memory network. It no longer contains that charge anymore. So they might do some more eye movements with you to clear the rest of the stuff in the body. Once the body's cleared and you don't have any of those sensations, then we can move into phase 7, which is closure. This is just where we debrief. So we first ensure that you're regulated and calm before you're going to leave the session. We have a closure statement that we read, just kind of lets you know, listen, things can still come up. It can open other things up, and if you do, you can reach out, make sure that you're resourced. And then you have support system, and we can, provide resources for you if you do have a limited support system. So once the client, or excuse me, once the clinician or the therapist ensures that you're prepared to leave, you're regulated as much as possible, and you have adequate resources, then off you go. And at next session, when you come back, we do phase 8, which is the final phase, and this is reevaluation. So we have you link that image that you brought up last time, bring up the positive belief of I'm in control or I am safe, and just notice if there's any disturbances or sensations in your body. So we just want to check one more time that nothing was left. There's no residual left over there and that it was actually completely cleared. Because with EMDR, if it works, which it's been shown to be about 80% effective, which is insane, if you ask me, for a treatment modality, efficacy. 80% is really, really high. So it's been shown to work about 80% of the time with clients. And when it does work, there should be no charge, right? It's kind of like trauma is an open wound and there's a bunch of debris in it, and EMDR helps you clear the debris, and then the wound can heal and turn into a scar. So scars don't hurt, they're just memories. And that's kind of what EMDR is able to do when it works. So we do the reevaluation phase to make sure that there wasn't something there that we missed. So here's a resource to Shapiro's book on EMDR, and then also one for the adaptive memory network or information processing system. I would also recommend that you personally get and read a book called Getting Past Your Past. It's by Francine Shapiro. It's called Getting Past Your Past. It's also on some of those audiobook apps like Audible or Scribd or whatever is going to exist when you listen to this. But Getting Past Your Past is an amazing book. It's good for clinicians, but it's also great for people who are either looking into EMDR or curious about EMDR or want to learn more about dealing with their own trauma. It's amazing, really, really good book. So if you enjoyed the information on EMDR and you're interested, that would be your best starting resource. You can also reach out to me for further information. If you want to identify a EMDR certified trained therapist, you go to the EMDRIA site, which is EMDRIA. So it's EMDR International Association, EMDRIA. I believe it's emdria.org. If you go there, you can find a list of clinicians and you can search by state or zip code. And all the clinicians listed, all the therapists listed on that website are trained in EMDR through the EMDRIA approved organization. So it might be through the Humanitarian Assistance Program or another, but whoever is on that site had to be trained by someone who is approved to provide training of EMDR. And then there's also people in there who are certified. Certified just means that they had a little bit more training, but the main thing is that they are able to train other clinicians as well. So if you have any questions, concerns, comments, or complaints, then please just go over to the website at www.theanxiousmammal.com and go to the About Me, and there's a contact section there, and you can email me whatever you need, questions, comments, concerns, and I will get right back to you. So next time we'll move into number 11 of 13. The next two are going to be about interventions. So not this EMDR, but other interventions like somatic interventions and things like that, things through the body. So we're going to get a little bit more into other theories and interventions that you can seek if you're dealing with trauma, or that you can look into for developing your expertise as a trauma therapist. So I'll see you at number 11, hopefully. Bye.